Okay, now when we talk about capnography, based on what I just said, you may think that the views on capnography are negative, and that's not at all the case. Capnography is a tremendous tool. In fact, I would go as far as to say that it is one of the biggest things that we have done from a technology perspective in critical care and transport medicine in a long time. Capnography is a vital tool. I would argue that every single patient that's intubated needs continuous waveform capnography, and most patients with respiratory failure, even if they're not intubated, or respiratory distress and not intubated, should also be on non-invasive capnography by nasal cannula or something like that. It is a tremendous tool. It's just understanding what its limitations are. So let's talk about capnography itself. Let's talk about the actual capnogram for just a few minutes. When we look at a capnogram, remember that a capnogram is actually broken up into 4 phases. We have phase 0, phase 1, phase 2, and phase 3. And the diagram that you see there to my side is a good example of a nice capnogram waveform. Remember, what we're looking for is a nice square waveform. And remember that when we talk about phase 0 is really where it starts, and that's the section that's in red. In phase 0, this is inhalation. As we're inhaling in, there's not a lot of carbon dioxide in the air. So in phase 0, what we see is there's a dramatic drop in the waveform. Now, where we really start to see our value in capnography is when we exhale. And when we exhale, we go through 3 different phases. Phase 1, phase 2, and phase 3. Phase 1 is the first part of this, and this is where we're basically exhaling what's in the dead space. And remember, the dead space is all those conducting airways that really don't have anything magical going on. There's no gas exchange. And so in phase 1, we really don't have any CO2 as well, because the main airways, your trachea and your large bronchi, they don't have any gas exchange. So phase 1 continues on down at the bottom of the waveform, just like we saw at the end of phase 0. As we move into phase 2 is where we start to have mixing. This is where the lungs that are, the air that was in the alveoli in the lungs starts to mix with some of that dead space air. And the further out we exhale, the more mixing there is, and the more it becomes alveoli, and the less it becomes that dead space air. So in phase 2, this is where we see the upstroke of the capnogram. This is where we're seeing more and more CO2 as more and more of the alveolar air is moving up and out of our airway. And then finally, phase 3 is where we see a plateau. During phase 3, all of our exhalation is all or I should say the vast majority of our exhalation is all air that's coming out of the alveoli, so it's got lots of CO2 in it. So again, phase 0 is when we inhale, phases 1 through 3 are as we start to exhale, and again what we're looking for is that nice square waveform when we're looking at capnography. Okay, now what are the values in capnography? Well, one of the biggest values to capnography, especially from a transport perspective, is the ability to confirm the airway placement in real time. If your airway is sitting in an appropriate depth, if it's at the right depth that it's supposed to be at that patient, and you've got a square waveform, then there's nowhere else the tube can possibly be but in the trachea, assuming the tube's not kinked or anything. If it's a straight tube at the appropriate depth and you've got a square waveform, then you have to be in the trachea. And this is the first real value for capnography, especially in EMS where we're constantly moving patients. If you look at extubating somebody, if you inadvertently extubate them and you wait until their pulse ox falls before you identify the fact that they're extubated, that may be a matter of several minutes, especially if it's a relatively healthy younger person. Whereas with capnography, if we've got a tube that's either positioned incorrectly, like in the esophagus, or a tube that becomes displaced, we will see that with the very next breath. We will see that almost instantaneously. So as long as you're watching your depth of your tube and you're watching your capnogram, you know that your tube is in the appropriate place. Now, one of the things that I do want to point out is that when we esophageally intubate somebody, in some patients there may be some level of CO2 in their belly. So while you would think that if you stick it in their belly you would just have a plain flat waveform, that may or may not be the case. You may actually have some amount of CO2 when you bag somebody in their belly, especially if they've just recently had any kind of carbonated beverage like a Coke or something like that. But the big thing that you will not see in somebody who's been intubated in their belly or whose ET tube is laying in the esophagus is that clear cut, square waveform. So that waveform is everything. And this brings us to a really important point. When we talk about capnometry, we're talking about the number, whether their EtCO2 is 32 or 42 or whatever. When we're talking about capnography, we're talking about the waveform, and capnography is much more valuable than capnometry. Really, that waveform is the key to the value of capnography. Okay, here's a good example of a capnogram, what it would look like if the patient stopped breathing or if the patient's tube was dislocated. You see, obviously, you've got a square waveform there representing a good breath, and then after that, the waveform just becomes flat. That obviously would tell us that the tube has either been moved into the gut or that the patient, if they were spontaneously breathing, has stopped breathing. Now, one other thing that we can get from capnography that's pretty important is we can actually get a measure of what their airway resistance is. And with bronchospasm, if the patient's airway is tight, we won't typically see a nice square waveform. Instead, what we see is that they have a rounding of their waveform as they exhale because it takes them a lot longer to push air out. Remember, we said exhalation was passive, and the tighter your airway is, the more resistant it is, the longer it's going to take for you to get air out. And you'll hear people oftentimes describe this as like a shark fin kind of pattern. So with that rounded waveform like that, that would suggest to us that the patient has a really tight airway. And so at that point, we would need to start thinking about things to relieve the pressure in the airway, whether it's beta-2 sympathomimetics or Atrovent or something like that. Okay, so we've talked about the three primary buffer systems, and we've talked a little bit about capnography. Now let's talk about the other buffer systems that are out there. There's two other buffer systems, actually there's three other buffer systems that can play a role in our acid-base balance. When we talk about other buffer systems, one of the other buffer systems aside our three primary ones is the protein buffering system. Remember that proteins in the body tend to be somewhere between neutral and slightly negative. So when you have lots of protein in your body, you have this intrinsic ability to buffer lots and lots of acid. And we know that we've got proteins in our body in multiple forms. We know that hemoglobin is a protein. We know that one of the major things in our blood vessels that holds in fluid, one of our major contributors to oncotic pressure, is something called albumin, and albumin's a protein. And then we have lots of other little proteins as well. The important thing to remember about proteins and acid-base balance is that if you have a patient who's got a low protein level, whether they have a low hemoglobin, whether they have a low albumin, or whether they have a low total serum protein, that means that the patient has less normal ability to buffer acid than the normal healthy person does. Okay, so who has low protein levels? Well, it's pretty simple. Pretty much anybody that's critically ill is going to have a low protein level. Certainly, people that have been in the ICU for more than a day or two, we start to see their albumin and their total protein go. So the takeaway point is when you look at a blood gas for somebody and you say, oh wow, this patient's really acidotic, their pH is 7.0, and you're looking through their labs and you also see that their albumin and their total protein are in the toilet, well, their ABG is actually, their actual acid-base balance is worse than what you see on their ABG because they've lost that ability to buffer those proteins. So, lost that extra ability. So the lower somebody's albumin is, the lower their total protein is, the more acidotic they are, and and remember that your blood gas is not going to compensate for that. So they're actually worse than what they look like on their blood gas. Now, when people are chronically acidotic, the other thing that can happen is we can actually have bones start to play a role as well. Bones actually have the ability to exchange calcium and phosphate and also have the ability to release carbonate. And the big thing that happens with these patients is because they're chronically acidotic and because they start to exchange calcium, phosphate, and carbonate, their bones start to weaken, so they become much more prone to orthopedic type issues. And good examples of patients who would have these types of issues, patients who are chronically acidotic, would be patients like with renal failure. Okay, when we talk about the buffering systems, the last buffering system that you need to understand really, really well is you need to understand ionic shifts. And remember that when we talk about ionic shifts, the big ionic shift that we always have to deal with in acid-base balance is the shift of potassium. So let's talk about this so that we understand this well. Remember that when we have a patient who becomes acidotic, as their hydrogen levels start to climb and climb in their bloodstream, hydrogen is going to do like what anything else is going to do. It's going to go down a concentration gradient. So let's say that I've got half the cells in my body that are not getting adequate oxygen, and because they're not getting adequate oxygen, they've converted to anaerobic metabolism, and I'm making lots and lots of lactate. Well, we know lactate is an acid, so we know that hydrogen levels are climbing and climbing and climbing. Well, that other half of my body, where the cells are getting enough oxygen, what's going to happen over time is the hydrogen levels start to climb in the blood. We're going to get to a point where there's more hydrogen in the blood than there is in those other cells. So what's going to happen? Well, hydrogen's going to move into the cells because hydrogen is going to go down its concentration gradient, always looking for equality. So as hydrogen moves into the cells, as hydrogen starts to move into healthy cells, all of a sudden you've got a lot of excess plus stuff in there because we know that hydrogen is a positive ion. It's a cation. Well, normally in your cells, you've already got lots and lots of cations, and the most prevalent cation that you have is potassium. Remember that potassium is your major intracellular cation. Well, in a normal healthy cell, because we've got to have equality, you've got all of this potassium, but it's all neutralized by all these anions that are in the cell. The thing is, most of the anions inside the cell are physical parts of the cell in the form of proteins. So you can almost think of them as being like the walls and the pillars of the cell. So those anions, since they're a physical part of the cell, they don't have the ability to move. They're just stuck there. They just are what they are. They're not moving, they're not increasing, they're not decreasing, they just are what they are. Well, as hydrogen gets dumped into the cell and the potassium that's already in there are mixed, we now have more pluses than we do minuses. We've now got we've got an excess of cations. Well, because there's an excess of cations and there's not enough anions for all the cations, something's got to go. Well, what's got to go? Well, what's most prevalent? Potassium. So as hydrogen starts to move into cells, at the same time as hydrogen is moving into cells, because there's an excess of positive ions, potassium starts to move out of the cells. Well, where does it go? It goes into the bloodstream. So as my hydrogen level in the bloodstream starts to climb, as I become more and more acidotic, hydrogen moves into the cell, and reflexively, potassium moves out of the cell into the bloodstream. So we come walking along and we draw labs on this patient, and lo and behold, guess what we're going to see when we look at our potassium? We're going to see that it's really, really high. Now, does that mean that it's high because that patient truly has too much potassium in their body? No, not at all. The reason why that potassium level is high is because it's been displaced out of the cells in the bloodstream by this patient's acidosis. And there's actually a formula we can use. It's actually pretty simple. For every increase in the pH, for every 0.1 change in the pH, we're going to see a 0.6 change in the K the opposite direction. So let's start with a perfect K and a perfect pH. Let's say we've got a perfect potassium of 4, serum potassium of 4, and we've got a perfect pH of 7.4. And let's say that our patient starts to become acidotic. So as their pH goes from 7.4 down to 7.3, I would expect to see that their potassium goes from 4 to 4.6. As their K goes from 7.3 to 7.2, I would expect to see that their K goes from 4.6 to 5.2, and so on and so forth. That's a normal change in potassium in relation to the pH. That's normal physiology. Now, as that potassium level starts to climb and climb and climb, the heart doesn't care where the potassium came from. All the heart knows is there's an excess of potassium in the blood. It doesn't care whether it came from the cells or it came from external or where. It just knows there's too much potassium, and as potassium starts to climb in the bloodstream, we start to see all those problems that we see with potassium toxicity. We start to see arrhythmias and bradycardias and all that good stuff. So the question becomes, how do we treat it? Well, when we treat hyperkalemia, remember that we basically have 7 strategies for how to treat hyperkalemia from a medical standpoint. The very first thing that we can do is we can give the patient calcium. The other thing that we can do is we can give the patient D50 and insulin together. We can give the patient bicarbonate, we can give the patient, bicarbonate, or we can also give the patient albuterol. Those are 5 strategies, and then the other 2 strategies that we have are we can give the patient Lasix and we can give the patient K-Exalate. Now let's talk about the way that each one of these works. First, when we talk about calcium, Remember that calcium isn't going to do anything to the potassium. All calcium does is compete. Calcium is a positive chronotrope and it's a positive inotrope. So basically when we give somebody calcium for their hyperkalemia, what we're doing is we are overdriving the heart. Now, when we talk about the insulin and D50, remember that when we give insulin and D50, D50 is going to want to cross into cells. Insulin is the bridge to allow that to happen. And anytime insulin allows the passage of sugar into cells, it also takes potassium with it. When we give somebody bicarbonate, again, we are helping to force potassium back into cells. And when we give somebody albuterol, the same thing. We are helping to force potassium back into cells. Now, what about those last two options, the Lasix and the K-Exalate? Remember, when we give somebody Lasix, what we're doing to drop their serum potassium is we're forcing them to diarrhea. So we're forcing them to pee, and as they pee, they're going to take potassium with them. When we give somebody K-Exalate, basically what we're doing is we're giving them diarrhea. And anytime they have diarrhea, we are also going to suck potassium with it. So the difference between these 5 over here compared to these 2 is that with all 5 of these things, with the calcium, the insulin D50, the bicarbonate, and the albuterol, we didn't remove any potassium from the body. We just moved it around. With these 2, with the Lasix and the K-Exalate, we are actually removing potassium from the body. So let's go back to our acidosis and potassium. So if the patient's getting more and more acidotic, and because they're getting more and more acidotic, their potassium is coming up and up and up, is the patient truly got an excess of potassium? We already said no, it's not an excess of potassium, it's just in the wrong place. It's in the bloodstream instead of being in the cells. So if I were to go down these routes over here, if I was to give the patient Lasix or I was to give the patient K-Exalate, I'm going to remove potassium from the body. And then when I go back and I fix the acidosis, what's going to happen to potassium? It's going to shift back into the cells, and what am I going to end up with? I'm actually going to end up with a potassium deficit. I'm not going to have enough potassium because I've wasted a bunch by peeing it out. So, taking this all and putting this all into practice. One of the most common errors that you see that's done in management of hyperkalemia is removal of potassium in patients who are acidotic. Anytime you get labs back on somebody and you see that they've got hyperkalemia or they're in hyperkalemic crisis, the big question is always, are they in hyperkalemic crisis because they've truly got too much potassium? Or is it that they're in hyperkalemic crisis because of the fact that they're acidotic? If they're acidotic, then we don't want to remove potassium from the body. We want to fix the acidosis, and we can use these drugs over here to help move potassium back into the cells. Whereas if the patient truly has an excess of potassium but is not acidotic, then it's appropriate to use drugs that are actually going to remove potassium, like Lasix and K-Exalate and things like that. Now, so let's take it and put it into practice. What if you see an EKG like this? What if you go in to pick up somebody, their EKG looks like this, and they're really, really hypotensive? Well, when we look at this EKG, the thing that should stick out at us right off the bat is the fact that this patient has very profound peak to T waves. There was an EMS educator that wrote a really good 12-week book years and years ago named Mike Tegman, and one of the things that he always said that stuck with me is if you ever look at an EKG and you look at the T waves and they look like they would hurt to sit on, you need to think hyperkalemia. So if it's hyperkalemia, the big question next is, what's the pH? If the pH is acidotic, then what we're going to focus on is pushing potassium back into cells and fixing the acidosis, and that's going to make our hyperkalemia better. If the patient is not acidotic and is truly hyperkalemic, for whatever reason, truly has too much potassium, then it's appropriate to use things like Lasix and things like that. Okay, now let's talk about the actual interpretation of ABGs. We've talked about the physiology behind it. Let's talk about how to interpret ABGs. And there's lots and lots of theories out there about how to interpret ABGs. I'm certainly just going to give one interpretation of how to do it. Okay, before we talk about interpreting ABGs, we obviously need to talk about what normal numbers are. So when we talk about normal ABGs, first we'll start with the arterial numbers. When we talk about a normal blood gas, a normal ABG or arterial blood gas, we know that a normal pH is somewhere between 7.35 and 7.45. When we talk about a normal CO2 is somewhere between like 35 and 45. And if you have a hard time remembering the CO2, remember that the CO2 is just the pH without the 7. So if you can remember a normal pH is 735 to 745, then you can remember a normal CO2 is 35 to 45. When we talk about a normal bicarb is somewhere around 22 to 26, and if you want help remembering that, just think, what is the age of the person that you would like to date? We would all like to date somebody who's 22 to 26. This tends to work better for men than women, though. Most women don't want a 22 to 26-year-old. Most guys want a 22 to 26-year-old. So that may or may not work for you. When we talk about the PaO2, we've already talked about that. Remember, we said the PaO2 is the amount of oxygen that is in the plasma, the partial pressure of oxygen that's in the plasma. And we said that's normally around 80 to 100. We've already talked about the SaO2 as well. Remember, the SaO2 is the amount of oxygen that is attached to hemoglobin. And remember, we said we measure that as a percentage. And ideally, what we would like to see in most patients is that their SaO2 is greater than 95%, certainly greater than 90%. When we talk about the base excess or the base deficit, we normally say that we would like it to be somewhere between -2 and +2, and we'll get back to that later. And what about venous gases? Well, when we look at a venous gas, let's think about this. When a gas is coming back through the venous system into the body, what do we expect to see? Well, we expect to see that blood that is returning to the lungs is going to have more CO2. And CO2 we think of as acidotic. So what do you think the pH is going to be? It's going to be more acidotic. So while a normal ABG pH is like 7.35 to 7.45, a normal VBG pH or venous blood gas is somewhere usually around 7.31 to 7.41. When we talk about a normal CO2, you see obviously that it's going to be a little bit higher, but you see it's not usually higher. It's only about 5 higher typically in a healthy person. So a normal CO2, a normal VBG CO2 would be somewhere around 40 to 50. A normal bicarb unchanged, somewhere around 22 to 26. And obviously, as blood is returning to the lungs, we see that blood returning to the lungs has got less oxygen in it because we just sent all this blood out through the body and cells consumed it. So the PVO2 is the amount of oxygen that's in the venous plasma, and we would expect the PVO2 to be somewhere around 35 to 40, and the SVO2 is the amount of oxygen that's bound to venous hemoglobin, and we would expect that to be somewhere between 70 and 75, which is pretty interesting when you look at the SaO2 compared to the SVO2. You'll notice a normal SaO2, we said it was somewhere greater than 95%, a normal SVO2 is somewhere between 70 and 75%, so a normal healthy person is only consuming about 20 to 25% of the oxygen that they have available to them. And when we look at the base excess or the base deficit, we see that those are also unchanged compared to an arterial blood gas. Okay, so when we talk about arterial blood gases, when we're going to actually interpret an ABG, remember there's some general rules to ABG interpretation. Remember that when we have a high CO2, we need to think acid. So you can, while CO2 is not directly an acid, you can basically think of it as an acid. So a high CO2 would suggest acidosis. A low CO2 would suggest alkalosis. When we talk about the bicarb, think exactly the opposite. Or if it helps you, remember that the bicarb changes in the same direction the pH does. So a high bicarb means alkalosis, just like a high pH does. A low bicarb means acidosis, just like a pH does. Now, remember that when we're talking about interpreting an ABG, we only need to interpret an ABG if one of 3 numbers is out of normal. So when we decide what an ABG is, whether it's a respiratory acidosis or metabolic acidosis or whatever, when we make that determination, we're going to make that determination based on 3 numbers. The only 3 numbers that decide what an ABG is are the pH, the CO2, and the bicarb. So the pH, the CO2, and the bicarb. If any one of those 3 numbers is out of whack, then we have to interpret the ABG. So if somebody hands you an ABG and you look and the first thing you see is that the pH is, say, 7.37, well, we know 7.37 is between 7.35 and 7.45, so is that ABG normal? Not necessarily. We can't say that ABG is normal until we've looked at the 2 other things, the CO2 and the bicarb. If all 3 of those numbers are normal, if the pH is normal, the CO2 is normal, the bicarb is normal, then it is a normal ABG and we don't need to interpret it. But if any one of those 3 numbers, the pH, the CO2, or the bicarb is abnormal, then we have to interpret the ABG. Okay. So let's look at when we assess an ABG, how we're going to identify it. Well, every ABG is going to have three names, which is something that we're pretty used to here in American culture. Most families here in America, most descendants here in America have three names. They have a first name, a last name, and a middle name. So that's pretty simple. You're going to see the same thing with an ABG. With an ABG, you're going to have a first name, a middle name, and a last name. Now, the good news is that for ABGs, we're very limited in our choices. For our first name is going to be compensated or uncompensated. It's that simple. First name is going to be compensated or uncompensated. Middle name is going to be respiratory or metabolic. And finally, the last name is going to be acidosis or alkalosis. Those are our two choices for each of the three names: first name, middle name, and last name. So again, first name is going to be compensated or uncompensated. Middle name is going to be respiratory or metabolic. Last name is going to be acidosis or alkalosis. Okay, so somebody actually hands you an ABG and says, look at this and interpret it. What do? Well, the first thing you do is you ask yourself, is anything abnormal? And remember, when I said anything, what I was talking about was the pH, the CO2, and the bicarb. If the pH, the CO2, and the bicarb are normal, then you're already done. The ABG is normal. That's simple. But if any one of those three things is out of whack, then we need to proceed. So step one is anything abnormal: pH, CO2, or bicarb. If we look and we say yes, then we go on to step two. In step two, the very first thing that we're going to do is we're just going to look at the pH. We're going to look at that one number. And based on that one number, we're going to get the first name and the last name. So when we talk about the first name, we said that for the first name we had two choices. We had compensated or uncompensated. Well, how do we determine which is which? Well, it's really simple. What's a normal pH? 7.35 to 7.45. Well, if we've looked and something is abnormal, and thus we're at step two, we look at the pH and we say, is it between 7.35 and 7.45? If the answer is yes, then the first name is compensated. I'll say that again. If we look at the pH and the pH is between 7.35 and 7.45, then the first name is compensated. Now, we also said that just from looking at the pH, we were going to get the last name. And remember, when we talked about last names, we said we had two choices. We had acidosis or alkalosis. So how do we figure that out? Well, it's really simple. What sits between 7.35 and 7.45? What's right in the middle? 7.4, right? So right in the middle of 7.35 is 7, and 7.45 is 7.4. So if the pH is less than 7.4, then it is acidotic. If the pH is greater than 7.4, it's alkalotic. It's that simple. So if the pH is less than 7.4, then it's acidotic. If it's greater than 7.4, it's alkalotic. So let's look at some examples here. Let's look at the first pH here. You've got a pH of 7.22. So the first question that we ask ourselves is it between 7.35 and 7.45? And when we look at 7.2, we know the answer is no. So we know the first name is uncompensated. The second thing we did was we asked ourselves, is it below 7.4 or is it greater than 7.4? And we know that 7.22 is less than 7.4. So we know that the last name is acidosis. So just looking at the first name or just looking at the pH, we got a first name and a last name for this blood gas. So 7.22 would be an uncompensated acidosis. Now let's look at 7.47. First name would be uncompensated because it's not between 7.35 and 7.45. Last name would be alkalosis because it's greater than 7.4. So this would be an uncompensated alkalosis. What about 7.28? First name would be uncompensated because it's not between 7.35 and 7.45. Last name would be acidosis because it's less than 7.4. Now what about a pH of 7.5? First name would be uncompensated because it's not between 7.35 and 7.45. Last name would be alkalosis because it's greater than 7.4. So this again would be an uncompensated alkalosis. So taking them from the top there again, you see 7.22, we see that that would be an uncompensated acidosis. 7.47 would be a uncompensated alkalosis. 7.28 would be an uncompensated acidosis, and a 7.5 would be an uncompensated alkalosis. Now what about 7.37? With 7.37, the first name would be compensated because it's between 7.35 and 7.45, and the last name would be acidosis because it's less than 7.4. So the last one there, 7.37, would be a compensated acidosis. So just looking at the pH, we've already got 2/3 of our job done in interpreting an ABG. We've already got a first name and we've already got a last name. Now, let's look at the third step of this. We've already figured out the first name and the last name, so really all we've got left to do is figure out what the middle name is. And the way we figure out the middle name is really simple. All we're going to do is we're going to look at the CO2 and we're going to look at the bicarb. And we're going to ask ourselves which one matches the last name of the pH. In other words, which one is acidotic or which one is alkalotic. And whichever one matches, that's going to be the middle name. So let's take this and put this into practice. Let's look at this ABG here. You've got 7.19 for a pH, you've got a CO2 of 66, and you've got a bicarb of 24. So let's use our system. First off, is everything normal? 7.19, nope, it's not normal, so we're already knocked out, so we know we've got to interpret the ABG. So we look at the pH first, 7.19. What's the first name and the last name? Okay, we know it's not between 7.35 and 7.45, so we know that it's uncompensated, and we know that it is less than 7.4, so we know it's an acidosis. So this is an uncompensated acidosis. So is it respiratory or metabolic? So we look at the CO2. The CO2 is 66. Is the CO2 is 66 acidotic, alkalotic, or normal? Okay. Should be acidotic, right? Because we said a normal CO2 was like 35 to 45, and we said a high CO2 suggests acidosis. So respiratory matches. The respiratory is acidotic, the pH is acidotic. But let's look at the bicarb too. The bicarb is 24. Is that acidotic, alkalotic, or normal? That is normal, right? Because remember that a bicarb we said was normally between 22 and 26. This is 24, it's right smack dab in the middle, so it does not match the pH. So which is the middle name? It's respiratory, right? So when we take that all and we put that together, we said the pH was 7.19, so the first name, last name was uncompensated acidosis, and the CO2 was 66, which matches, so that makes it an uncompensated respiratory acidosis. Okay, let's look at another one. Let's say you've got a patient who's got a pH of 7.27, a CO2 of 37, and a bicarb of 14. So rule number one, is everything normal? pH is 7.27, CO2 is 37, bicarb is 14. No, everything is not normal, so we need to interpret the ABG. So when we look at the pH, first name and last name are what? It's an uncompensated acidosis, right? It's not between 7.35 and 7.45, so it's uncompensated, and it is less than 7.4, so it is acidotic. So we ask ourselves again, which one of these two numbers, respiratory or metabolic, matches? The CO2 or the bicarb? The CO2 is 37. Is that acidotic, alkalotic, or normal? That is normal. When we look at the bicarb, is the bicarb acidotic, alkalotic, or normal? The bicarb is acidotic, right? So which one matches the pH? The metabolic side matches the pH. The bicarb matches the pH. So 7.27, we said that's an uncompensated acidosis, and we know from looking at the respiratory and metabolic sides that it is an uncompensated metabolic acidosis. Okay, let's look at another one. 7.58, first name and last name. We know that 7.58, we know that that does not fit between 7.35 and 7.45, so we know that the first name is uncompensated. When we look at 7.58, that is obviously higher than 7.4, so we know that it's an alkalosis, so it's an uncompensated alkalosis. Now when we look at the respiratory side, the CO2 is 14. Is the CO2 of 14 acidotic, alkalotic, or normal? Well, we remember that a CO2 of 14 would be alkalotic. When we look at the bicarb is 22. Is that acidotic, alkalotic, or normal? We remember that a bicarb of 22 would be normal because the normal bicarb is between 22 and 26. So which one matches the pH? It's respiratory. So what would we call this? We would call this an uncompensated respiratory alkalosis. This is an uncompensated respiratory alkalosis. Okay, let's look at another one here. Here you've got a patient who's got a pH of 7.48. You see that their CO2 is 41 and their bicarb is 30. So question number one, is anything abnormal? Well, 7.48 is obviously abnormal, so yes. So the question becomes, what is the first name and the last name? So when we look at the pH, 7.48, the first name is, it's uncompensated, right? Because it's not between 7.35 and 7.45. And we know that it is acidotic or alkalotic. It's alkalotic, right? Because it's greater than 7.4. So this is an uncompensated alkalosis. Again, we've got to ask ourselves which matches. Is it the respiratory side or the metabolic side? Which one matches the pH? So when we look at the respiratory side, the CO2 is 41. Is that acidotic, alkalotic, or normal? We know that that's normal because a normal CO2 is between 35 and 45, so that's sitting in the middle, so that's normal, so that doesn't match. When we look at the metabolic side, we see the bicarb is 30. Is that acidotic, alkalotic, or normal? We know that that is alkalotic, right? Because a normal bicarb is 22 to 26. Anything less than 22 would be acidotic. Anything more than 26 is alkalotic. So which one matches the pH? It's metabolic. So we know this is an uncompensated metabolic alkalosis. Okay, let's look at this one right here. You've got a patient who's got an ABG that shows you a pH of 7.09. Their CO2 is 60 and their bicarb is 14. So is anything abnormal? Yes. When we look, obviously 7.09 is out of whack. So is the CO2. So is the bicarb. Okay, so this needs to be interpreted. So we go back to our same question, first name, last name. When we look at the first name, we know that this is not between 7.35 and 7.45, so we know the first name is uncompensated. And when we look at the last name, we know that this is less than 7.4, so the last name would be acidosis. So this is an uncompensated acidosis. So the question becomes, which one matches? So when we look at the respiratory, we see the CO2 is 60. When we have a CO2 is 60, is that acidotic, alkalotic, or normal? We know that a CO2 is 60 would be acidotic. We know that a normal CO2 is 35 to 45. Anything above that would be acidosis. And when we look at the bicarb, we see that the bicarb is 14. Is that acidotic, alkalotic, or normal? Well, we know a normal bicarb is 22 to 26. This is 14, and we know that anything less than 22 would be acidosis. So which one matches the pH? Well, this blood gas, you see both match the pH. You've got respiratory acidosis and you've got metabolic acidosis. So what in the world do we call this blood gas? Well, there's two ways that we could call this blood gas. If we were following our little formula, we could say that this is an uncompensated respiratory and metabolic acidosis. And that would be completely appropriate. It would be a little bit of a duplication because we're saying it's uncompensated when obviously it's uncompensated. Or we could, or the other way that you'll hear this termed is you'll hear people call this a mixed acidosis. A mixed acidosis is when both numbers point the same way. Same thing with a mixed alkalosis. A mixed alkalosis is when the pH and both numbers, the CO2 and the bicarb, all point the same direction. So this patient has both things going on. This patient has a respiratory acidosis and a metabolic acidosis. Again, we could call this an uncompensated respiratory and metabolic acidosis, or we could just say this was a mixed acidosis. Okay, so we figured out first name, last name, and all that good stuff. There's one step left to do. There's one final step, step 4, and we only have to do this if one thing exists. Only and only if the first name was uncompensated. I'll say that again. Only and only if the first name was uncompensated, we need to look back at one last thing. We need to look back at the CO2 and the bicarb again, and whichever one did not match the pH, in other words, whichever one is not the middle name, we need to ask ourselves, is it going in the opposite direction? what the pH and the number that matched are going. So in other words, if the pH and the number that matched are both acidotic, then we want to know the number that didn't match, is it alkalotic? If it's going the opposite direction, then we are going to change the first name, and it's going to be changed from uncompensated to partially compensated. So let me just say this again to make sure that it makes sense. If and only if we've done our first name, middle name, last name, and the first name, if the first name was uncompensated, then we're going to look back at whichever number did not match the pH, and we're going to ask, is it going in the opposite direction, either acidotic or alkalotic, the opposite of what the pH is doing. If the answer is yes, then we are going to change the first name from uncompensated to partially compensated. So let's look at a blood gas here that's a good example of this. So you've got a pH there of 7.33, you've got a CO2 of 68, and you've got a bicarb of 34. So we're going to follow the process exactly like we've done all along. So the first thing we ask ourselves is anything out of whack? Look at the pH at 7.33. Yes, that's out of whack. Okay, we've got to interpret the ABG. Next thing we do is we ask ourselves, what is the first name and the last name? We said for our first name we had two choices, compensated or uncompensated. So when we look at this, 7.33, it does not sit between 7.35 and 7.45. So this patient, this ABG, the first name is uncompensated. The second thing we do is we look and ask ourselves, is it acidotic or alkalotic? And we know this is less than 7.4, so we know that this is acidotic. So this is an uncompensated acidosis. The next thing that we do, step 3, is we ask ourselves which of those two numbers matches. So we look at the CO2. Is it acidotic, alkalotic, or normal? Well, we know that a CO2 of 68 is acidotic. We know that a bicarb of 34 is alkalotic. So which one matches? The CO2. So we know that this blood gas is an uncompensated respiratory acidosis. Because our first name was uncompensated, we have this last step we have to do. We have to look back at the bicarb and see, does it go in the opposite direction? In other words, is it alkalotic when everything else was acidotic? And we look there at the bicarb at 34, we know that a bicarb at 34 is alkalotic. So therefore, we change the first name from uncompensated to partially compensated. And what that tells us is that the patient is trying to compensate for their acidosis by increasing the amount of bicarb. That tells us there's compensation. And especially with respiratory acidosis, this is a very important step to managing ABGs, because when we talk about management of respiratory failure, a big part of it is whether or not it's chronic respiratory failure or acute. And people with acute respiratory failure in those first couple hours will not have compensation. They will have an uncompensated respiratory acidosis. But if the patient has had a CO2 that's been high for a long time, like if they're a COPDer, they develop compensation. So they will have a partially compensated respiratory acidosis, and the treatment for that is going to be a little bit different. So it's really important that we identify in the patient who initially has an uncompensated disturbance, is it truly uncompensated or is it partially uncompensated? And again, to do that, all we have to do is look at whichever number did not match the pH and ask ourselves, is it going in the opposite direction? Okay, so let's look at some blood gases where all of those things are out of whack. Let's look at some blood gases where all three numbers are out of whack and walk our way through them. Okay, so the system's going to stay the same. First thing we did was we asked ourselves, is anything abnormal? Second thing we did was we came up with the first name and the last name from the ABG, from just the pH, and then we ask ourselves, is which one matches? And then and only then, if the first name was uncompensated, then last but not least, we're going to look and see if the number that did not match is going the opposite direction. Okay, so let's look at this first blood gas here. We've got a pH of 7.17, a CO2 of 15, and bicarb of 14. So when we look at the pH, question number 1, is everything normal? When you look, obviously everything is not normal, so this blood gas needs to be interpreted. So the second question becomes, what's the first name and the last name? So when we look at 7.17, the first name would be uncompensated, right? It's not between 7.35 and 7.45, so the first name is uncompensated. The second thing we ask ourselves is it an acidosis or an alkalosis? Remember, our cutoff was 7.4, and this is less than 7.4, so we would say that it is a acidosis. So we've already got our first name and our last name. We know this is an uncompensated acidosis. Now, we look at the CO2 and we look at the bicarb. The CO2 is 50. Is that acidotic, alkalotic, or normal? That is acidotic, right? So that matches the pH. But we also have to look at the bicarb. Is the bicarb acidotic, alkalotic, or normal? That is also acidotic, right? So we have two different acidoses here. And remember that when both things match the pH, we said there was two ways that you could say this. You could say this is an uncompensated respiratory and metabolic acidosis, or the better way to say it is this is a mixed acidosis. And the reason why it's also better to say it's a mixed acidosis is because if you say it's an uncompensated respiratory and metabolic acidosis, then because it's uncompensated, we would have to go back and look to see if the other number that doesn't match is going the opposite direction. But we already know there isn't a number that doesn't match. Both numbers are going the same way. The CO2 and the bicarb are both going the same way as the pH. So it's just easier, it avoids that whole step if whenever you see all three numbers going the same way, whether it's acidosis or alkalosis, if you just call it mixed and then whatever it is. So if all three numbers are acidosis, we would just say it's a mixed acidosis. If all three numbers are all alkalotic, we would just say it's a mixed alkalosis. Okay, let's look at another one. What about when we've got 7.26, a CO2 of 84, and a bicarb of 38? Okay, so 7.26, is that within normal limits? No, so we've got to interpret the ABG. So when we look at 7.26, the first name would be uncompensated because it doesn't sit between 7.35 and 7.45. And the last name would be acidosis because it's not... because it's less than 7.4. So we've already got our first name and last name. We know this is an uncompensated acidosis. So the next thing we do is we look at the CO2. The CO2 is 84. If the CO2 is 84, is that acidotic, alkalotic, or normal? That is acidotic. We know that a CO2 of 84 is acidotic. And we look at the bicarb and it's 38. Is that acidotic, alkalotic, or normal? That is alkalotic. So which one matches? The CO2 matches, right? So when we look at 7.26, 84, and 38, we know that the first name and last name were uncompensated acidosis, and we know that this is a respiratory acidosis. So it's an uncompensated respiratory acidosis. Now remember we said that if the first name was uncompensated, we had one other thing that we had to do. We had to go back and we had to look at the bicarb and ask ourselves, is that going the opposite direction? And we know that a bicarb at 38 is alkalotic, so we know, yes, the bicarb is going the opposite direction. So we changed the first name from uncompensated to partially compensated. So in the end, what we should have ended up with is we should have ended up with a partially compensated respiratory acidosis. Okay, let's look at another one. 7.51, a CO2 at 29, and a bicarb at 37. So are all three numbers in normal range? No. So we have to interpret the ABG. So when we look at 7.51, what's the first name and the last name? Okay, you should have come up with it's a uncompensated alkalosis. It's uncompensated because it's not between 7.35 and 7.45. It's an alkalosis because it's greater than 7.4. Now the second thing we ask ourselves, or I should say the third thing we ask ourselves, is which number matches. Well, the CO2 is 29. Is that acidotic, alkalotic, or normal? A CO2 at 29 would be alkalotic. And when we look at the bicarb is 37. Is that acidotic, alkalotic, or normal? That is also alkalotic, right? So when we look, we see alkalosis, alkalosis, alkalosis. So we know that this is a mixed alkalosis, right? So this is a mixed alkalosis. Okay, let's look at another one here. When we look at this blood gas, we've got a pH of 7.17, we've got a CO2 at 31, and we've got a bicarb of 4. So when we look at the pH, the bicarb and the PaCO2 are all three numbers within norms. No, all three numbers are not normal. So we need to go on and we need to interpret. So once we decided we needed to interpret, the first thing we did was we looked at the pH and we got a first name and a last name. And we know the first name and the last name are... We know this is an uncompensated acidosis, right? The 7.17 is less than 7.35 to 7.45. It's not within that range, so it is uncompensated. And we know it's less than 7.4, so we know it's acidotic. So it's an uncompensated acidosis. So the next question is, which number matches? So we look at the CO2, it's 31. Is that acidotic, alkalotic, or normal? The CO2 is alkalotic, right? So that doesn't match. The bicarb is 4. Is that acidotic, alkalotic, or normal? We know that a bicarb of 4 would be acidosis, right? So when we look at this one, we know that this is an uncompensated metabolic acidosis. Because we've got an uncompensated metabolic acidosis, the last step is we have to go back and ask ourselves, is it truly uncompensated? So we look at the CO2 because that was the one that did not match. It was the one that was not acidotic. And we ask ourselves, was it going in the opposite direction? And we already said the CO2 was alkalotic. So we know it is going in the opposite direction. So we change the first name to a partially compensated metabolic acidosis. And what that CO2 tells us is the patient is blowing off CO2 in an attempt to normalize their pH. And that's exactly what we would expect them to do. In fact, we can make the statement that in metabolic acidosis, it is normal physiology to hyperventilate because that's the one thing we can control quickly. And if you think about that, that's exactly what you see. When people are in shock, what happens to their breathing? It increases. When people have DKA, what do they get? Kussmaul's. It's because they're trying to get rid of CO2. So a partially compensated metabolic acidosis is normal for a patient who's in metabolic acidosis. We expect them to be partially compensating. Okay, let's look at one more here. You've got a pH of 7.49, you've got a CO2 of 33, and you've got a bicarb of 4. So when we look at this one here, pH is 7.49, CO2 is 33, bicarb is 34. Is everything normal? No. So since everything is not normal, we need to go through and we need to interpret the ABG. So second question becomes looking at the pH, what's the first name and the last name? And when we look, we know that the first name is uncompensated because it's not between 7.35 and 7.45. And we know that the last name is alkalosis, right? Because it's greater than 7.4. So we know that this is an uncompensated alkalosis. The question becomes which one matters or which one matches. And when we look at the CO2, it is 33, and we know that a CO2 at 33 is acidotic, alkalotic, or normal. We know that a CO2 at 33 would be alkalotic, right? And when we look at the bicarb, we see that a normal the bicarb is 34. Is that acidotic, alkalotic, or normal? That would also be alkalotic, right? Because a normal bicarb is 22 to 26. Anything lower than that's acidotic. Anything higher than that is alkalosis. So when we look at this blood gas, we know the pH is alkalotic. We know the CO2 is alkalotic. We know the bicarb is alkalotic. So we know that this is a mixed alkalosis, right? And so this patient has both respiratory and metabolic alkalosis, a mixed alkalosis. Okay, once we've interpreted the ABG, once we've actually got that done, the next thing that we need to do is we need to look at a couple other numbers on the ABG to also elicit some important information. One of the things we want to do is we want to look at the PaO2, and we've already talked about the PaO2 a bunch. We said the PaO2 is the amount of oxygen that was in plasma. Remember that we said a normal PaO2 is somewhere around 80 to 100. Now, does that mean that somebody's on a non-rebreather? If somebody's on a non-rebreather, they should have a PaO2 somewhere around 80 to 100. The answer to that is no. We should not expect that because remember the PaO2 is derived from oxygen being moved from the alveolus into the plasma. And remember we said oxygen is going to move from the alveolus into the plasma until there's equalization, assuming that there's the ability to move oxygen. And so as we increase the amount of oxygen that we're giving somebody, we should expect to see that their PaO2 goes up as well. And so when we look at somebody's PaO2, it's not a matter of is it between 80 and 100. It's a matter of is the PaO2 where it should be based on the amount of oxygen that the patient's getting. Well, how in the world do we figure that out? Well, it's actually pretty simple. Whatever the patient's FiO2 is, whatever the amount of oxygen that they're on is, if you take that percentage and you multiply it times 5, that will give you a very rough ballpark of about what their PaO2 should be. And if you take that and make it concrete, it makes sense. Let's say that we're sitting in this room right now that's got an ambient oxygen percentage of 21%. Well, just to make the math simple, let's say that it's 20%. So if it's 20%, we multiply 20 times 5, that would give us a PaO2 of around 100. Well, we already said a normal PaO2 is around 80 to 100, so if you're a really healthy person right now sitting in a room with ambient air, you should be getting a PaO2 somewhere around 80 to 100, probably closer to 100. Now, what about somebody who's on 50% oxygen? What should their PaO2 be? Well, if they're on 50%, if we take 50% and we multiply it times 5, we should get 250, right? So if you've got a really healthy person and you put them on a FiO2 of 50%, we would expect that their PaO2 would be somewhere around 250. Now, the problem is that obviously the sicker you get, the more this breaks down. And so we're not necessarily concerned about what the absolute value is, like if they're on 50%, they should be 250. What the PaO2 really does for us, the real value in it, is watching to see if the interventions that we do for people make them better or worse. And here's a good example. Let's say that you go to get somebody, or you have a patient that's coming into the ICU that you're going to take care of, and this patient is on 40%. And on 40% oxygen, you draw blood gas on this patient, and their PaO2 is only 50. Their PaO2 is only 50. Well, on 40%, what will we expect them to be? Well, 40% times 5 would be 200. So we would expect that patient's PaO2 to be 200, but it's only 40. So what kind, or excuse me, it's only 50. So what kind of deficit does that patient have? Well, 200 minus 50 equals 150. So that patient has a deficit of 150 compared to what they should be. Now let's say you do a couple things for this patient. Let's say that you nebulize this patient and you put them on a non-rebreather, and so you bump them up. Let's say you get them on a non-rebreather and you get them on 70%. And so now that you've got them on 70%, you wait 30 minutes and you go back and you draw another blood gas. And let's say when you draw the blood gas, their PO2 has gone from 50 to 60. Is that patient getting better or getting worse? Well, initially you see that their PaO2 went from 50 to 60, so you think, oh, they're getting better. But remember, we increased them to 70%. What is 70% times 5? Well, 7 times 5 would be 35, so 70% times 5 would be 350. So we would expect that that patient's PaO2 now should be 350. Well, what's 350 minus 60? 350 minus 60 would be, what, 290? So now we've got a deficit of 290. Remember, before we had a deficit of 150. Now we've got a deficit of 290. Is that patient getting better or are they getting worse? That patient is actually getting worse. So just because you look at the PaO2 and the number is getting better doesn't necessarily mean that the patient is getting better. Now, does that mean that all those things that we did for them made them worse? No, not at all. Giving them oxygen and giving them bronchodilators and all that stuff, could have very much been the very appropriate thing to do for that patient. But what that tells us is we're not keeping up with their disease. They're getting sicker faster than we're making them better. So that patient's actually got a decrease in their oxygenation, and that patient's in trouble. And we need to start thinking about what else we're going to do for that patient. So that's the real value in the PaO2. The other thing that we always want to look at on the blood gas is the base deficit. Now, when we talk about the base deficit, the big thing you need to know about the base deficit is it's not a measured number. When I say a measured number, I mean it's not like we stick a syringe and somebody pull out blood and we're measuring the amount of base that they have in their body. That's not what the base excess or the base deficit is. When we talk about the base excess or the base deficit, we're talking about a calculated number. It's a number that's calculated based off of what the patient's pH is and what their CO2 is. And the machine does that for us. It calculates a base excess or a base deficit for us. Now, the other thing you need to know is that whether you see it as the base excess or the base deficit, it's the same number. It's not two different numbers. It's just whether it's a positive number or a negative number. And so a perfect base, if you will, base would be 0. If the patient had a base excess or base deficit of 0, that would be perfect. If the number is negative, like -1, -7, -19, If it's a negative number, we call that a base deficit. If it's a positive number, like 7, 13, 21, we call that a base excess. And what the base excess or the base deficit tells us is basically about the metabolic side of things, and it tells us is the patient getting better or getting worse depending on what their condition is. And remember, what we're always shooting for is to get closer to zero. If the patient has metabolic alkalosis, they are going to have a base excess. If the patient has metabolic acidosis, they are going to have a base deficit. And the worse the acidosis, the worse the base deficit, the more negative the number. If the patient has alkalosis, the higher the number, the more positive the number, the more alkalotic they are. So we're always trying to get them closer to zero. And the big advantage to the base deficit is it doesn't tell you anything more that you're not going to have figured out already by interpreting the ABG, whether it's acidosis, alkalosis, or whatever. But what it does tell you is a very quick picture of whether the patient's getting better or worse. And so I'll give you a good example. Let's say that you're working in the trauma unit and you have a patient who comes in and the patient's got multiple injuries, the patient's got multiple fractures, they've got pneumothoraces, they've got a fractured pelvis, they've got a hot belly, this big multi-system trauma patient, say from an MBA. And let's say as soon as they walk in the door with your very first IV insertion, as you're getting the patient set up, you get a set of gases off that patient and you see that the patient has a base deficit of -10. Let's say that you get the patient intubated, you get bilateral chest tubes put in, you fluid resuscitate the patient with 2 liters, you get 2 units of blood going, and on your way to the OR, you get another blood gas. And now the patient's base deficit is -20. Is that patient getting better or worse? Well, you've moved farther negative, so that patient is getting worse. Again, does that mean that all the things that you did for that patient were wrong? No, not at all. It just means that you're not keeping up with the disease process. The patient is dying faster than you're treating them. Conversely, let's say that you had done all that stuff and you got another blood gas and the patient's base deficit had gone from -10 to -4. Is that patient getting better or worse? The patient's getting better because they're getting closer to zero. So trauma surgeons especially love to use the base deficit because in trauma everything we're dealing with is lactic acidosis, and so when we're dealing with lactic acidosis we can really quickly look and see is the patient getting better or getting worse based off the base excess or the base deficit. It's almost mindless. The more negative they are, the more acidotic they are, the more positive they are, the more alkalotic they are, and it gives us a very quick snapshot. Are we moving in the right direction or are we moving the wrong way? Okay, wrapping up this section here, let's just talk about a couple other little quick rules to ABGs. One of the other rules that we can use to help us confirm that we're interpreting our ABGs correctly is remember for every change in the CO2 of 10, I'm talking acute changes here, not slow chronic changes, but acute changes. For every change in the CO2 of 10, we should expect that the pH is going to drop about 0.08 in the opposite direction. So, if I've got a perfect CO2 of 40 and I've got a perfect pH of 7.4, if I hyperventilate my patient a little bit and I drop their CO2 from 40 to 30, then I would expect to see that that patient's pH would go from 7.4 to 7.48. Conversely, if I've got a perfect pH of 7.4 and a perfect CO2 of 40, and I hold my breath and I watch my CO2 go from 40 to 50, I would expect to see that my pH would go from about 7.4 to about 7.32. So it's just a quick little way to double check yourself. And again, that these are rough estimations. But you can also target with your ventilator and with your CO2s where you want your CO2 to be based, or where you want your CO2 to be based on what your pH is. And remember that whenever we're talking about managing ABGs, the most important number on an ABG is the pH. It's not about the CO2, it's not about the bicarb, it's about the pH. So we can manipulate the CO2 and we can manipulate the bicarb however we need to get the pH within the range that we want it to be. Okay, another golden rule: for every 10 change in the bicarb, or for every change in the bicarb of 10, we should expect to see that the pH will change about 0.15 in the same direction. So remember, with the pH and the CO2, they go in opposition. With the pH and the bicarb, they go in the same direction. So if I've got a perfect bicarb of 24 and a perfect pH of 7.4, and I get metabolic acidosis and my bicarb drops from a perfect 24 down to 14, I would expect to see that my pH would go from about 7.4 to about 7.25. Conversely, if I give the patient a bunch of bicarb who's got a perfect bicarb already, and they go from a bicarb of 24 to a bicarb of 34, I would expect their pH to go from 7.4 to about 7.55. So for every 10 change in the bicarb, I should see the pH change about 0.15 in the same direction. Finally, the last little rule that you need to know is how to calculate bicarb replacement for a patient who's got metabolic acidosis. I'm going to give you the formula, and then we're going to talk about it for a minute. So when we talk about the formula, the way that we figure out how much bicarb we would have to give somebody to get them all the way back up to a normal pH is we take their weight in kilos, we divide that by 4, and we multiply that times their base deficit. So for instance, if I had a 100 kilo patient, 100 kilos divided by 4 would be 25. And let's say they've got a base deficit at 10. We just use the absolute value of 10. So 25 times 10 would be 250. So that patient would need 250 milliequivalents of bicarb to get them back up to normal, or 5 amps. Now, having said that, I want to mention a couple things about bicarb replacement real quick. The first thing about bicarb replacement is remember that most of the time, bicarb is not indicated for metabolic acidosis. Contrary to what we've been taught for years, that is not the mainline treatment for metabolic acidosis. And we're going to talk about why in the next section when we talk about metabolic acidosis. We're going to spend a lot of time talking about why bicarb is not as great as we used to think it was. The second thing about bicarb is in the rare instance where we actually correct the patient's pH with bicarb, remember that we typically want to do that slowly so that we give the time necessary for electrolytes to switch. So in that rare instance where we actually decided that we were going to use this formula, that we were going to use their weight in kilos divided by 4 times their base deficit, what we would usually do is give half of that bicarb as a bolus and the rest of that bicarb over a couple of hours. So we don't just slam the patient with 250 milliequivalents of bicarb. We would give them half of that now and then half of that over the next couple hours so that their electrolytes have the chance to equilibrate. Okay, we're going to wrap up this hour here. It's actually been a little over an hour, but we're going to wrap up this section here. And when we come back, we're going to talk about the different types of acid-base balance disturbances and what to do for those different things.
I'd come for you, no one